Test 1 2 3. Testing 3 2 1.
have three policies. Who's Wanda's coming up? First is the RI 3000 Visitation Policy. Wanda. Good afternoon.
I have three policies for your approval this afternoon. The first is our visitation policy. Just basically speaks to how we have patients present.
Approval.
Is there a second?
Second.
Second from Amanda. Discussion from anybody? All in favor, please say aye.
Aye.
Those opposed, same sign. Death postmortem policy, PC 2000.
So it's pretty straightforward. It just talks about that
I'm
we
sorry?
do postmortem. There's not much to report on this. It just states that we do it.
Move approval.
Second from Amanda. Discussion.
All righty then, I'll start at the beginning.
What do you want the
It may take a while to do that. This last one, I will say something about, oh, did you approve? I'm sorry.
We need to vote. Please vote. All in favor, please say aye.
Aye.
Those opposed, same sign. Okay, number three.
Okay, actually, I will say something about this last one. This last one is our risk assessment and identification for the management of obstetric hemorrhage. This is part of our maternal levels of care, and this policy is actually worth $3.4 million for our DISRIP program, and your approval is required in order to get this approved.
Okay. Good work.
Okay. Move approval.
Approved. Second from Zim. Discussion. All in favor, please say aye.
Aye.
Those opposed, same sign. Now we're down to stuff that does not require committee action, but it's definitely performance improvement. Rob, you're up. PS 190. Good afternoon.
Well, before I start with my presentation, I do want to introduce a new face in the room, which is our new Executive Director of Quality Operations and Implementation, Allison Windaws. She has joined us most immediately from Shriners Hospital in Greenville, South Carolina, where she served effectively as Chief Nursing Officer. She also served nationally on the Quality Committee for Shriners and led numerous major system-wide quality initiatives there. And before that, she ran quality for the Helen DeVos Children's Hospital in Grand Rapids, Michigan, which is part of the Spectrum Health System. So we are very glad to have her on board, and she's already doing a great job. So you'll welcome her.
Welcome. Are you finding your way around? I mean, that's one of Zim's questions all the time.
So actually, that's why Sean was so proud of me, because I actually made it here on my own for the first time today. So yes, Sean has been my guide and invaluable. So I'm starting to find my way around.
Well, you can ask me if you need help. Yeah. Don't go where Zim's going and you'll find your way, because we've lost Zim a couple times.
Okay.
So
Sorry for the interruption, Rob.
that's all right. So over the last several weeks, we've been talking about how to deliver more information to the Quality Committee, how to sort of beef it up, how to make it more useful to the board so that you all understand better the work that it is that we do here. At a recent HR committee meeting, Reverend Emerson actually, challenged me to tell you all how it is that we do the good things that we do around here when they happen, so you have sort of a deeper understanding of the work that we do. So today, just as a point of introduction of kind of where we're going in this meeting, we're going to have 4 different presentations. The first 2 are presentations that we've been doing pretty much all along. So we're going to talk about PSI 90, which is our pillar goal for quality. We're also going to be talking about patient experience. So those 2 pieces have been part of the quality board really since I've been coming before you. The second 2 presentations are the different ones. And so the first one really goes directly to the question of how is it that we do the good work that we do around here? What do we use things like data for? How do we respond to it? And so for that first presentation, I thought it would be great to bring before you the work that our behavioral health team does in terms of meeting the standards for core measures, which are a Joint Commission mandated measure that we report and follow. And then the final presentation of the open session will be from one of our team members who, in response to patients really not being ready for surgery like we'd like them to be, a lot of them needing to get canceled day of surgery because they weren't ready medically or having increased rates of complications. We made the decision a number of years ago to actually create a surgical optimization program so that we are doing very intentional, focused work around getting patients ready for surgery. And the reason I thought it would be timely to bring this before you in what I'm now calling Innovation Corner, because it's something new that we're doing for our patients, is that there was a really nice Channel 5 news story about this, and so we'll show you the news story. Diane St. Pierre, who's here, will make a brief presentation about the work that she's doing and some of the results that they've been seeing, and you'll have an opportunity to ask her some questions about that. So that's just to sort of lay out what open session is going to look like. But we'll jump into PSI 90. So, so this is now our first 4 months of the fiscal year. Our current rate is now up to 0.92, which is slightly above our rate from last year. The reason is, and you can go to the next slide, that our January was a little high. Remember, I've been telling you that month to month this measure bounces around a lot. And for those of you who don't remember, PSI 90 is a measure of how we're supposed to perform with regards to our patients with respect to a series of hospital-acquired conditions that are reflective of harm that our patients may be experiencing in the course of their care. So if you hit 1, this is supposed to be like an observed over expected. If you hit a score of 1, that means you're performing as expected. If you're above 1, that's less well than expected. And if you're below 1, that's better than expected. So in January, we're a little high. There were a couple of reasons for that. Number one, we had a postoperative sepsis. Any month that you have that, that's going to hit your number pretty hard. And the reason is that that's a very highly weighted measure. So if you have a postoperative sepsis, if you have a postoperative respiratory failure, postoperative renal failure, those are infrequent but rated high or weighted high. So if you get just one of those in a month, that can push you up a lot. The other thing is that we had a patient who had been here for 2 years in the hospital. He was in our jail unit for roughly 2 years, and he happened to get to leave the hospital, or at least leave our hospital and go down to the state facility at Galveston. And but he had a deep vein thrombosis about 1.5 years ago, but that doesn't hit us until they actually go home. So if you have patients who, for whatever reason, are in the hospital for a long time, that lagging of, so even if you put 10 million things in place to improve your rate of something, since that discharge date is when that actually gets measured, that can harm your numbers a little bit. So that's the reason for January. Just to give you a little foreknowledge, it looks like February may be our best month ever since we've been following this measure. So month to month, this is going to bounce around, but it's really, as we look over longer periods of time, year or 2 years, that's when these measures become a lot more valid. So anyway, so currently we're still in goal range. We're ahead of target, not at stretch, and we'll go from there. Okay.
Question for anybody?
I have a question.
Yes.
Could you go back to the other slide?
Yes, please.
That's based on, this is the information that you're using to create that slide, right?
That's correct. Yeah, that is correct. So you can see for the year we now have 3 DVT or PE. We have 1 respiratory failure. They're all very, very small numbers because you're not really supposed to have very many of these events. Okay? But it does mean that in any given month, one measure can really push you one direction or the other. So So it is important to look at this measure over a period of time. Any other questions?
Okay.
Okay.
Very good. I think it's good this information, people finally get to understand it. Here comes Miss Laura. Hey.
Good afternoon. Thank you for having me. The first thing that I would like to review is our organizational goals and where our fiscal year to date results are. So as our HCAPS dimension, as you recall, is for us to achieve top quartile performance, so 75th percentile and above. That's a national ranking for our dimensions of care, which I'll get into in a little deeper level on the next slide. Currently, we are at 4 dimensions of care that are achieving 75th percentile or above. On the outpatient side, we measure that by questions. There are 10 questions that we measure, as there are 9 dimensions on the HCAPS inpatient survey. The outpatient questions, we did this a little bit differently, where we're showing you top box percentages. So if you recall, the answer choices that patients get for their surveys are, generally speaking, always, usually, sometimes, or never. Always is considered a top box answer. There's one question that rates the overall rating of the provider, which is a 0 through 10 rating scale, and we get credit for 9s and 10s. So what you're seeing on that percentage is the number of patients, the percentage of patients who selected a top box answer. So generally speaking, that would be they selected always, or they rated us a 9 or a 10. Does that make sense so far? So on the inpatient side, what you're seeing here in this graph are the dimensions that are measured. This is, again, part of the CMS HCAP survey. And the green bar that you see represents the last year's results, and the blue bar represents this year's results. The reason that we are measuring the way we are on the inpatient side is that allowing us to really pay close attention to each of these dimensions allows us to have a holistic approach to the way that we take care of our patients. So as you look and you see each dimension, so care transitions is a dimension, cleanliness.
What does that mean?
Care transitions actually measures 3 questions. One of them is, did we take the preferences of the patient for their after discharge care into account? So for instance, did we talk to them about when their physician appointment would be, their follow-up appointment would be? Did we take into account who is at home taking care of them, and did we partner with the patient in that way? It has to do with meeting their preferences. That's one of the questions. Another question is around discharge instructions, and another is around medications for the care transitions dimension. Cleanliness and quietness is 2 questions, basically. One is how clean, was the unit, and the other is, was it quiet, and how often did that occur? So again, these are the same rating types, always, usually, sometimes, and never. We get credit for top box answers only. We also have a communication with nurses, communication with doctors, communication about medications, discharge information, an overall rating question, how responsive was our staff when the patient needed something, and then would we recommend the hospital. So these are, there are questions under each of these dimensions, but this is the roll-up that you're seeing here. The top number that you're seeing that's in white, that's a little bit larger, is the percent positive. Again, the percentage of patients that rated us at the top answer choice. And then underneath it, you'll see percentile ranking. So you can see where we fall in each of those dimensions compared to the rest of the country.
I'm sorry, say the last bit again.
Sure. The number that says PR equals, and then there's a number, see that? That's the percentile ranking, and that's where we fall in relation to every other hospital in this country. Yes. Other questions? Yes, Dorothy.
On the care transition, that's the one that looked like our percentile ranking is so low. Is it that we don't ask the question, or?
Yeah.
Help me understand that
Yeah,
question.
I think it's, every hospital nationally is really struggling with this dimension. It is the hardest one, I believe, to move. It has to do with a lot of coordination and collaboration with case management and social work and the clinics on the outpatient side. And so our opportunity really is around creating processes and systems that allow us to do that better, frankly. But nationally, you're going to find the highest performing hospitals are just over 50% on the positive number. So, we're right now 3.5% below that. But it's a hard one to move.
Okay, all right, thank you.
Yes, no, and we work on this, and we'll continue to do that in a pretty robust way because it's the right thing to do for our patient. Other questions on inpatient? On outpatient, yes.
Yeah, so on these we have for FY '20, is this year to date? Are we still measuring because all of them seem to dip down just like a little bit?
Yes, there's actually a lag time in the data response, so it takes us about 6 weeks to be able to get data in, and December traditionally tends to be a harder, we hit flu season and it becomes a little bit of a challenge, frankly, because the volumes go up so significantly. So once we level set, you'll start to see that improve as well.
So this is probably through like end of the year, end of 2019
Yeah.
kind of.
Yes. It takes, again, about, they close the data for the month, but it's usually about 6 weeks after the month closes. So you can kind of assume that right now we are looking at some January data, but it probably is not closed yet.
Anybody else?
The other thing I was going to say is, this is really, the work that we're doing is really about alignment and about hardwiring and creating consistency. And so as far as our organizational goal is concerned, we do a lot of work with our physicians and with Acclaim so that we align their goals with our goals. And on the outpatient side in particular is the first time we've really been very successful with that this year. And so I do think that when you have that type of alignment, you should start to see things move in an even better way. What I'll do on the inpatient is focus on a dimension per time we're together so that we can go a little bit deeper into those. Today I'll go deeper into the communication with physicians and talk about some of the work that's happening there. On the outpatient side, these are questions, and again, the green bar represents last year's data, and the blue bar represents this year's data. There is not a percentile ranking for this survey, so you're only seeing top box answers, top box responses, meaning, again, they chose always, yes, definitely, or a 9 or a 10 on this survey. The questions are similar to the dimensions, so but it's very provider focused in the clinic setting. Questions? Sure.
Now, there isn't any percentile ranking for this?
There is not.
Okay, so we're just comparing to ourselves?
We are comparing to, well, we do get the average rates of improvement and that kind of thing from NRC, but this is a new survey that we're doing, and this is not a CMS regulated survey. And so there is not a percentile ranking available for us yet. There may be in the future, but right now that is not available. So yes, on this we measure against ourselves, on the other we measure against and again, I want to be clear on the inpatient side, the database that we're looking at is every adult hospital in the country. So there's 5,500 of them or so that are in this same database. So when you look at being in the top quartile as our goal, that is a tremendous feat. Okay.
Laura, I would hope that in these first three where we're not doing very well on the outpatient, we see significant improvement.
On the
Hope we will.
on the outpatient side? Oh, as far as the percentage, you mean?
Yeah,
Yeah.
seen by a provider in a timely manner.
Yeah,
I mean,
that's actually within 15 minutes of them arriving at the clinic. So that question becomes really challenging too, but you're right. I mean, I think as the industry is changing and things become faster and more accessible for American culture in general, we have to figure out ways to do that. Yeah. And the provider to the medical history is one that we have been working on, and we will continue to do that because it's, you know, traditionally in medical school, you're trained to say, so what brought you in today? Well, all that says to a patient is you don't even know who I am, right? So we're having to retrain that technique with all of our physicians to say something like, I've read your information and I understand that you're coming in today for abdominal pain, but I'd love to hear a little bit more from you. And then allowing the patient to share, and that's a shift. These are hard things to get every single person to do. But we keep plugging away. We keep plugging away.
Easy to get the appointment is the one that bothers me probably the most.
Yeah, yeah. And we actually, that particular section of this survey, we actually rotate questions through so that we know, was it easy to get an appointment by phone? Was it the length of time? Was it accessed by my chart? So we actually measure a few different things in that particular area. And then action plan on that. Yes.
So on the survey for that particular question, does it follow logic? So if they say, no, it wasn't easy to get an appointment, then they ask additional questions, or is it just questions?
No, it is, so the surveys themselves are set up, that's a great question, actually. I wish it did that. It doesn't. The way that the survey is set up is to measure consistency of our practice. What that means is the question would read something like, I think, how often was it easy for you to get an appointment? And the answer would be always, usually, sometimes, or never.
So would we be able to see some of the,
Yes.
as you're analyzing, are you seeing some of the differences? Are there other improvements that we've found?
Yes, so I'll go over these as well. What I'm going to focus on today actually covers both inpatient and outpatient, and I'll show you one of the tactics that we have put into place and the outcomes that we're getting from that. And I'll do the same thing with all of these every time I come back so that I can try to explain what's involved in each one and what we're doing in order to move the perception of our patients and the care that they provide so that it becomes even more human-centered than what we do today. Yep. Any other questions on inpatient or outpatient? I listed out some of the things that we are working on. This certainly is not an exhaustive list, but I think worth mentioning. Every month, one of our patient experience managers meets with our leaders on the inpatient side and the outpatient side, and they action plan based on what those results are seeing. And so we have very specific plans that are happening all over the network, whether it be with an inpatient unit manager or an outpatient practice manager. And we also, once those action plans are put into place, a member from our patient experience team collaborates with the leadership, and we do observation rounds to see, is that actually working? Are we experiencing, and are our patients experiencing what we expect them to experience while they're in our care? So those are happening constantly throughout here. Every month, all the time, it is consistent. Our discharge calls are currently done in our towers, so for all of our med-surg units, our critical care units, and we're adding outpatient surgery next. And we are finding that there are some trends that we're experiencing, and so we are then working with those departments to help create a bridge or change the process that we use or change the way that we actually provide that service to patients. And those have actually, we just changed this a couple of months ago, so I'll be able to have some data to show you in the next couple times that we meet. But that actually, I think, will make a huge difference for us. So there's a team of 4 in there now. One of them hasn't started yet, but there are 3 people who make calls to every single person who discharges from our inpatient units and our on the towers, our critical care units, and then we're also adding the surgery.
When do they do them? 24 hours, 48 hours?
No, they're here just during the day, so they make up to 3 phone calls to a patient, And then they trend that information, and then again, action plan on that with the appropriate departments. So if we find, for instance, that there's a challenge that our patients are having with getting medications, then we would partner with pharmacy and partner those units together so that we work in a very coordinated effort in order to make that better for our patient.
Thank you.
Mm-hmm. We also have our ambassador program that is 450 or so. We're getting ready to add 50 more tomorrow, 52 more tomorrow. And that is frontline team members. And we actually just educated them on our organizational goals and gave them an activity to bring back to their departments so that we can really provide that communication from peer to peer at the frontline level. And that has proven to be a good source for us to cascade information throughout the organization. A strong care for the caregiver program that our behavioral health team, our spiritual care and ethics team, our EAP, and our director of well-being and academic affairs put together a plan so that we take care of our caregivers who are taking care of our patients, and that's a critical role that is allowing us to improve their engagement levels and also decrease their levels of burnout.
Tricia got very excited back there.
Yes. Yes, Zelia, Tricia, and I partner as the executive sponsors on that program, so it's really great. And then we do a lot of work with our diversity and inclusion team, too, with the Serving with Sensitivity curriculum that you all are familiar with. Our clinician learning experience happens once a month at lunchtime. It's part of our trauma talk now. And so we end up with usually somewhere between 30 and 50 clinicians who come in on a monthly basis to learn about a patient experience technique or a topic, and those are actually taught by physicians, and we prep them from our team so that we really are pushing ownership to where it needs to be. And then the Patient Experience Mastery Program is really what I wanted to expand on today and share with you a little bit about this. I'm going to re-show a video that you saw a few weeks ago because I want to set the context for this, and it's hard to remember how everything fits together. So if we could play the video.
It was light, it was life-giving.
Brings us all together as a team.
The way you sit in your chair, writing notes in front of them.
It's reignited the passion, it's reignited the excitement of taking care of patients. And we do that well at JPS. So the Patient Experience Mastery course is an innovative means by which we can pull together our community of providers and clinicians. It galvanizes the trust. It allows us to work together to find best practices and new ideas to convey pearls of wisdom and skills and tools that we use to improve our patient care. We look at the needs of the patients from their perspective, and we talk about better ways to listen and better ways to connect.
It really helped me retrain my thinking about every patient experience that I had.
It was more introspective, it was light, it was life-giving. You as a human being. I didn't expect to learn more about myself and how I approach people and how I come off to people and really think beyond patients, beyond patient care.
I think all of us come to work every day really wanting to give our patients that feeling of acceptance and that we care so much about them, because we do, but sometimes our body language or the way we enter the room or the way we speak with them doesn't always portray that. And so for providers, it can be very frustrating because we want so badly to portray that to our patients, but sometimes just with simple little changes to the way we act in front of them can make a huge difference.
It's really given me a new excitement to use all the tools, and one kind of builds on the other, and then you end up doing several and you do them over and over, and you see the patient's reaction and you see them relax, and their joy on their faces just kind of gives you more joy as a provider, and it's really kind of put a new, renewed energy into my job and what I do every day.
The power of connectivity is remarkable, and this course has taught us more and more how to do that.
Even though we all work in different areas, we all have a similar purpose, and learning and hearing what they do and how I can put that into practice in my own area was invaluable.
So the mastery program is a 10-week course. We have two tracks running at the same time. So we have one for the operational side, and we have one for our physicians and APPs, who you saw on that video were members of our first cohort who graduated in November. And we had 55 people who graduated in November. They are then given an internal certification for patient experience, and they become masters in it. And the model is really built around learning, doing, and then sharing. And it is, again, peer-led, so we prep the facilitator for teaching the session, and what we find is when you learn from peers, you learn differently, and when you learn something to teach it, you learn differently. And so we're creating owners throughout the organization. We have our current, we have 2 cohorts going right now, one for our OBGYN residents, which we're running research projects on both of these, by the way. Tricia can get excited about that too. So we have one running for our regular cohorts that are those who are already out of their residency, and then we have one in the residency. And this is a 10-week course. You can see the topics that we cover here. The 10th session is not anything new, but rather putting everything that has been learned over the course of the last 9 courses into play. And so we'll show different scenarios, and they will say, here's what's missing, here's what I saw, here's, that kind of thing. They are very activity-based learning sessions, micro-learning content with more activity in the end. And so it was interesting. They're a lot of fun. There's 2 goals to this. One was to build just the foundational elements of patient experience and what patients want and what they expect when they come to a visit or they have an inpatient stay, but also to create community with our care teams. And that in itself has become really an invaluable part of this, in that they're meeting people that they never would have met, and they're experiencing things together. And so the sense of community has been just tremendously strong through this, and one of, I think, the biggest outcomes of it. But on the last slide, what I will show you is what the results are. On the outpatient side, we can actually pull out all of our physicians individually. What you see in the top graph are those who went through that very first cohort of our mastery program. So some of the members that you saw in the video. Interestingly, Elizabeth Smith, I don't know if you all know this, she's actually a descendant of John Peter Smith. So she was in our very first cohort as a graduate, so it's kind of fun. But what you see at the top are the questions that are directly related to the communication dimension of physicians. So did the provider explain things? Did the provider listen? Did the provider show respect? Did the provider spend time with the patient? And then an overall rating. The lighter blue bar, or the left-hand bar, shows where we were at baseline. So we took all of our physicians and APPs that participated in cohort 1, and we pulled their results, and those numbers are where they ended, or where they were. That was their baseline. On the right-hand side, that graph shows where they were in that July through October timeframe when they were attending class. So you can see that there's significant increases in their numbers. Now, just to remind you, the national average rate of improvement last year that we were trying to achieve on the outpatient side was 0.3. So when you look at this and you see 2 and 3 and 4 percentage points improvement, that is very far beyond what an average was for physician improvement in these questions. We then took everybody else. So we pulled all of our physician data, all of our APP data, and we pulled out those who were in the cohort. And the bottom graph is what you see there, which has either declined or is relatively flat. And so what we know is that when we bring attention and we bring awareness and we begin to teach people in a fun way about the fundamentals of what patients are wanting and what they're expecting in their care delivery today, you can really see that there is a vast difference in their performance levels in the class or not in the class.
Lori, you said
Yes.
This is an average of all providers.
Yeah, that were in the cohort.
To the provider level.
I can, yeah. On the outpatient side, we can actually drill down to the provider level, which is how we got that. We were able to pull out the data this way.
Do you share it with those providers?
We did. What's interesting is during the mastery course, we show them kind of what the survey looks like, and we go over it in class number 1, which is nuts and bolts, and we never talk about scores again. We only talk about doing the right thing for the patient and how to do that, and then we showed them their scores at the end. And they were all excited, you know, that this actually worked and that they saw a difference. And so then, of course, you know, it makes you want to do more, but yeah. So I'm a firm believer that if we are doing the right thing for our patients, the score moves. The score reflects that work. And I think, you know, that's been our approach here, that it's not about a number. It's really, it's more than a metric. It's really about doing the right thing. What questions can I answer for you? Yeah.
Like the initial cohort was
Higher.
the higher performers to
Yes.
begin with, right? And then obviously
And they move.
I'm just curious from your perspective, do you think that when you get some of the providers who score a little bit lower, do you think you'll see the similar delta, or you think you'll see an even bigger jump?
Yeah, so I don't know is the question. We're in it right now. Traditionally speaking, the lower your score is, the easier it is to move it. So on the, for our higher performing individuals, they're already doing a really great job with patients. This was really about moving from good to great kind of thing. And so I anticipate that we will see that number move more significantly in our next cohort. But, and they're so engaged. It is, it's really, it's a lot of fun. And they're laughing and getting to know each other, and it's a lot of fun. So, yeah.
And how is selection into the mastery program?
So the first group we actually called and said, we have a new program that we want to start and we'd like for you to be a part of it. As the cohort graduated, we asked them for referrals, and then we called those referrals, and we personally invited them to join. And some joined in the spring, and some are on the list for the fall. We have another session starting in the fall. I invite you to join us anytime you wish for this, if you would like to just see it. The classes are 50 minutes long, so they start at 5:30 and they end at 6:20. And they are, they're fast-moving, they're very activity-based, but you are more than welcome to join us. They're on Monday evenings.
That's where, Tim, don't you teach one of these? Good part of it?
Where is he? Oh, yeah, he has been my partner in crime on this. So Tim has been just a tremendous, tremendous partner in allowing us to be able to take all of this and really provide it to our physicians and APPs in a way that's been really meaningful. So,
Good.
yeah, can't say enough
Good,
about
good.
Dr. Kramer. Other questions that I can answer for you?
Comments for?
Which, by the way, on the last slide where the slide that says what questions can I answer for you, that's actually a tactic that we teach to our physicians, because traditionally we say, what questions do you have? And it's really, or do you have any questions? And the patient, it's really easy to say no. This actually elicits conversation from a patient, so this is one of the tricks that we teach during the mastery course, that if you'll ask an open-ended question, you can actually get to a place where you can explain things in a much better way, and at the same time, patients feel like they were treated with respect. So, thank you very much.
That's good. All right there. Behavioral health, core measures, Celia. Oh, bringing up the whole team.
Good afternoon. I wanted to go over with you all what are called inpatient psychiatric core measures. So core measures for inpatient psychiatric facility quality reporting was developed as a mandate by the Social Security Act, and it began October 1st of 2012 as a CMS pay for the reporting program. In order to be eligible, you have to meet all of the program requirements. And the intent of the program is obviously to improve the quality, but also to inform consumers as they make their choices in healthcare providers. The penalty payment for not reporting would be 2% annually in a reduction. And so along with what CMS quality standards are and along with what the Joint Commission quality standards are, we have to follow all of those, but then on top of those, these also we have to follow. And so if we'll go to the next slide. It's called HBIB, so it's Hospital-Based Inpatient Psychiatric Services. That's what that acronym stands for. And our first core measures, we have our physical restraint, which are the hours of physical restraint by 1,000 patient hours. And year to date, we're at 0.04, and the state average is 0.09, and the national average is 0.38. So we are well below, which is good, the state average, and significantly doing better than the national average in that category. The same for seclusion. Year to date, we're at 0.14. The state average is 0.2. And the national average is 0.29, and a lot of hard work has gone into that with our staff here. At JPS, we've been implementing trauma-informed care with our clinical staff, which means that we use more compassionate, empathetic verbal interventions in order to relate to where our patients are coming from versus saying, oh, that's just somebody with schizophrenia, or oh, that's just somebody that's depressed. And our staff have really bought into those changes. We've had trainers come in from the outside. Our staff actually now are all fully trained in trauma-informed care, and we'll begin quarterly training classes in August. And Dr. Potawiltz and our provider group have also gone through some of the training as well and have been instrumental in our success.
But what have you learned?
What have we learned?
Yeah, in your training, what have you learned? I like
Very
it.
nice.
Most importantly, be kind. You don't know what other people have experienced in terms of trauma. They can be big traumas or little traumas, but we all react to those in some negative way. And just being sensitive to that and beginning to ask the right questions about what in your life can I do better? What do you not want me to do? What do you want me not to ask? And to respect the patient for what they have experienced.
And where they are.
Good.
And also too, I think emotional intelligence and where you are too, self-care is a big part of it, and taking care of yourself as a caregiver for behavioral health patients and recognizing your limits and where you can do better personally as well. So there's an aspect of that as well.
So if if someone calls you a name, 10 times in a row, you may want to say, I think I need to take a break so I can decompress and get myself back centered. Because at 11th time, I may want to just say something negative back.
Right. We're human.
All right. Thank you.
Discharging patients on multiple antipsychotic medications and the justification for that. Year to date, we're at 60%. The state average is at 69%. National average is at 61%. And Shannon, and this is Shannon Sims, by the way. She's our executive director of nursing for psychiatry. And you all know Dr. Potawiltz. She'll be talking about some of our action plans that we've put in place. The tobacco use treatment offered, the state average is 81%, national average is 81%, and we're at 87.3%. Tobacco use treatment means we have to, if a patient says, oh, I don't want to quit smoking, we still have to set up an appointment for them to get, while they're here inpatient, for them to get counseling when they leave. And so year-to-date, we're at 67.3. The state average is 37%, and nationally, it's 46%. Tobacco use treatment provided or offered at discharge, and tobacco use treatment at discharge. And actually, there's a good story with this, and I'm going to let Shannon share that part as far as the action item goes. We do a lot of screening for substance use disorders and do brief interventions as well. As you can see, we're at 100% year-to-date on all of them and 99.3% on the last one. So we are well above the state and national averages in all of those categories. We have these assessments and interventions hardwired within our EPIC medical record so that it prompts our clinical teams that are doing their assessments and evaluations. We also have hard stops with these because since they're core measures, we can't afford to not hit the mark on them. And so having the EPIC EMR allows us the ability to do that and make sure we're hitting on all levels. Any questions about what I've shared thus far? Okay, I think our next step is going to be, Shannon, you talking a little bit about action items, and Dr. P?
Sure. As Zelia said, I'm Shannon Sims. I'm the Executive Nursing Director for Behavioral Health. So Dr. Stevenson asked that I talk really loud, so I don't know that I need a microphone. He asked that I come and share some of the hard work that's gone into these core measures for behavioral health and action planning behind some of our successes, which I'm happy to do. But I have to say that a lot of this is due to the collaboration not only within our department in behavioral health across disciplines, but also with the quality department as well. Meeting with the abstractor, Emmanuel, regularly, and having him take me through the chart measure by measure to understand where he's going to look for the data, I think has been instrumental. And since that meeting about a year ago has stemmed a great relationship and partnership in really meeting these measures. So we'll start with HBIPS 5, which is one of the original measures. This metric looks at patients that are discharged on multiple antipsychotic medications with appropriate justification. And so with this measure, not only do we have to give, Joint Commission gave us 3 reasons, and only 3 reasons that we can choose for the appropriate justification. One of the barriers with this metric is that the N number is very small. We have a tendency not to discharge that many patients on multiple antipsychotics, so it may only be 1, 2, 3 a month. So if we miss it, then it looks kind of bad. But in the middle of last year, we saw some opportunity, and when I heard that they were having a provider skills fair, I seized the opportunity and personally myself worked the station at the provider skills fair where we provided education to 70% of the providers and 80% of the residents on core measures specifically that the providers touch.
Good.
So it was a long 2 days. So, and then also we added core measure education to the orientation process for providers and our new residents, which we had not done in the past, which I think has been very beneficial. And then also partnering with our friends in the quality department, they send an email whenever we miss this measure. And so it goes directly to the provider that may have missed it or that missed it, and then also Dr. Podolwitz as well for follow-up, and then tracking for performance improvement.
I asked, why didn't you do it?
So next we're going to be talking about tobacco 2 and its subset 2A. So tobacco 2, this looks at any patient that's screened positive for using tobacco products within the past 30 days or previous 30 days before admission, who were offered or provided counseling while they were inpatient, and then also nicotine sensation. So this is where it gets a little tricky for nursing in particular. It almost feels as if we're taking the patients right away because the 2A measures only if they did receive the nicotine cessation. So we're basically almost forcing a patch or gum. And previous to last year, we were only offering, I think, patches. And my experience has taught that patients will chew nicotine gum a little easier than they will a patch. So as long as we can get them to at least accept this gum one time, we'll meet the measure. And so we're working really hard at that. When we were looking, we had lots of opportunity with this measure a year ago. And so we've worked really hard. We identified a knowledge deficit with just behavioral health core measures really across the board in each discipline, nursing and with the providers as well. So we provided education, and we added that to orientation as well. We looked at nursing workflow and documentation opportunities in EPIC, just really trying to utilize EPIC as much as we could with any kind of notification that we may have missed a documentation. We implemented a chart audit process with the dashboard. We audit 100% of our charts, and then we review that dashboard monthly in a nursing manager meeting. And then also we receive the same email from the quality department if we miss the measure, either to nursing or the provider. And then tobacco 3 and 3A. So tobacco 3 is, it looks at patients that have used nicotine and whether they are offered follow-up counseling and a prescription for nicotine cessation at discharge. So tobacco 3 looks at if we offered it, and then tobacco 3A is if they received it. And so with our great partnership that we have with Quality, we noticed a plummet in this score back in, I want to say, September. And we really started, we were like, what's going on? I had know it was October, actually, because I had just done the skills fair, and I was like, I know the providers know about this. And so my plan's not working here. And so what we did in working with Emmanuel, Brenda Gomez, and within our department, we were able to identify that an order had been turned off in EPIC that we were using, the providers were using to set up outpatient counseling. And so because we didn't have that order, we were missing both measures.
That's right. It was actually November when we switched to the new template.
And so on, when you were looking at the scorecard, we were in the red. I'm happy to say we've already gotten it back up to like 60%. So once we got that order turned back on, we were good. So it was working with our friends in Quality, we were able to identify that deficit. We also provided education across the board, and the same as looking at the workflow and documentation in EPIC, and we received the same emails if we missed this measure too. So briefly, the last slide just kind of talks about, those were the ones that we put a lot of work into, and then Dr. Stevenson says, well, how are you maintaining green and all the others? And so I'm happy to talk about that as well. With our, Zilli kind of touched on the restraints and seclusion. We've done a lot of work with verbal de-escalation, trauma-informed care. We're really trying to self-care for our employees and what we can do to better support them. So there's been a lot of work that's gone into that. With our substance abuse measure, sub 2, this is alcohol use brief intervention offered during admission. So anyone that has identified an issue with alcohol abuse, we start them on what's called the CWA protocol, which is it's pretty widely used. And then detox protocol. It's a detox protocol to prevent detox. And then sub 2 is if they actually receive that. And so we're scoring very well on it. And it's partner measure sub 3, which is looking at, are we offering them treatment options at discharge, which we're 100% at that. And a lot of that has to do with Emmanuel coming over Quality and doing actual staff meetings with our staff and providing us with a template so that we can meet that measure when we're discharging our patients. So that's a lot of information.
And I think the other thing to note too is that we have a department-wide dashboard with our providers as well as nursing operations, and so it's a joint quality dashboard, and that is something that we sat down with our providers, with Dr. Podewiltz and his team and our leadership team almost a year ago? A little over a year ago now, and looked at what do we jointly share, what can we jointly impact, and so all of the core measures are on there, as well as our ED throughput metrics and length of stay and things like that. And so, you know, we're all from a department-wide, enterprise-wide, you know, we're on the same page as far as what our goal is, because they're shared, and what we need to do to get there, and where we are, and how do we need to help each other to get there. And so I think, obviously, looking at some of our core measure data, you can see that we're all on the same page.
What that did is it actually established ownership for the entire department for these. That it's not like, oh, this is something that you own, or oh, this is something that you own. It really is, we all own this, and so we all have, you know, responsibility to make sure that each of the core measures are moving in the right direction.
Any questions?
What's your definition of trauma-informed care?
Definition of trauma-informed
what is it?
care. Well, we've spent 2.5 days at a training to bring that back here to campus. I don't have the exact definition in front of me, but trauma-informed care, though, is for us as clinicians to understand, number one, that our patients did not get here by accident. They have experienced some type of trauma in their life, whether it be a big trauma or a little trauma. It's a trauma nonetheless, and as a result of that trauma, they have developed maladaptive behaviors in order to cope with the emotional conflicts of that trauma. And so our job is to acknowledge the trauma, but acknowledge them as a person too, and to give them an idea that there is hope, that their behaviors can be changed, not by us, but by them. We can give them the tools in order to change their behaviors and create an environment that is supportive and healing and hopeful. Because if they have hope, they always have a chance. And so that is what trauma-informed care is.
Good.
What does OFI stand for?
Opportunity for improvement.
We just want you all to know, as board members, we spend a week and a half prior to committees going over every possible word that could be confused, or any
We even had it at the
acronyms.
beginning, hospital-based impact.
Yeah, exactly.
That's all I ask.
No, well, not only will you ask, but it's interesting because it's an industry that works off of acronyms and abbreviations. And you begin to talk abbreviations all the time, and then sometimes you'll get caught off guard and someone will say, what is it? Well, I've been using that abbreviation for the last 3 years. Oh, I didn't realize that was the whole name. So it's pretty amazing.
We could write paragraphs with abbreviations. We really could.
Any other questions?
Good work.
Well, thank you, and we appreciate you all giving us this opportunity. And again, partnership with our quality team has been really amazing on this journey.
Instrumental.
All righty, well, thank you. The Innovation Corner.
All right, so this is our last little segment, Innovation Corner. We're going to talk about surgical optimization. I would like to introduce to you Diane St. Pierre, who is our lead APP in our surgical optimization program and has really designed the program, created it, and continued to strengthen it over the last several years. We're going to start by showing a video, which was the Channel 5, little brief Channel 5 news story about this program, which aired last month.
Diane St. Pierre says her mission is very clear.
We can see you weekly if I need to. I can see you twice a week to get your diabetes under control.
It's called the Surgical Optimization Clinic at JPS.
They don't want to be told you have to lose weight.
Roughly 60% of patients in need of surgery are not in optimal condition to have the procedure done. The problem, they're often left on their own.
You're told, I need you to go lose weight, but no one explains how.
Cheryl Beck is a cancer survivor who's prepping to have a hernia removed. She was told to drop pounds before surgery, something she admits she couldn't do on her own.
Oh, I wouldn't be able to do it. I'd be cheating all the time.
So patients were being canceled the day of surgery for elevated glucose, hypertension that was not well controlled, or their weight was too much for the surgery that they were going to have.
The clinic stepped in to change that with exercise, nutrition, and medication. Starting with just 11 patients in the first month of 2016 to more than 300 today. St. Pierre says it's life-changing for them and for her.
It's like, it's like you're doing mission work every day.
In Fort Worth, Candace Sweat, NBC5.
And I'm crying again. So for the month of February, we actually saw 365. And only 2 of those weeks were where we broadened up our schedule because we've moved into a new space now. So the main reasons patients get canceled same day is they are either smoking, which puts them at a very high risk for surgical site infection, MRSA infection, wound breakdown. If you're doing abdominal surgery, like a ventral hernia repair, if your BMI is too high, you've got a very high risk of that surgery failing, and then you have to repeat the surgery. Nutrition support, we've got, if your albumin is less than 2.8, and some surgical specialties now less than 3.5, it severely impairs your ability to heal.
And the albumin is the amount of protein in your blood.
Sorry.
So if you don't have enough protein in your blood,
Then you're not going to heal.
correct.
Yes. So we'll go put your colon back together, and then it's going to fall apart, and then we've created a ginormous mess. So we can fix that.
Very disappointing.
Yes.
It is heartbreaking. The glycemic control is a really big problem, not only at JPS, this is like nationwide, and one of our biggest obstacles is clinical inertia. A lot of it is education, a lot of it is comfort, a lot of it is, I don't think I can get my patient that really good drug, and a lot of times we can. So we've actually gone and taken extra courses on how to treat advanced diabetes management. When we perform optimization, we reduce the risk of delirium, which is now something that we're being measured on the inpatient side. We are able to perform prehabilitation, so we can do a time to get up and go test if they're frail and determine you need to see PT before you go to surgery. Here's an incentive spirometer to exercise your lungs before you go to surgery to get you through anesthesia better.
Next slide.
So we see all the joint replacement patients, which is a joy, and we see all the elective colon surgery patients. With the colon surgeries right now, we're performing an enhanced recovery after surgery protocol. This protocol is multimodal, multidisciplinary. It is shown to reduce hospital length of stay, it improves surgical outcomes, it reduces surgical site infections, so it's a win for everybody.
Next.
Sorry. Post-op complications increase not only the length of stay, but the cost associated with the hospitalization, and it's no fun for that patient. Go ahead next. So in fiscal year 2018, on the left, that's our colon surgical site infection rate. There are 2 boxes. CMS does not count superficial, like skin infections, and the national database does. So we had 16 in 2018, we had 12 in 2019, and we had 2 so far, fiscal year 2020. The optimization clinic started October of 2016. Next. This is our hip prosthetic surgical site infection. We're a little bit proud. 2018 we had 8, 2019 there were 11, and so far we have had 0.
And it was really in 2019 that we started directing all of the hip replacement patients, because we saw this rising rate of incidence of hip and knee surgical site infections. And so one of the things that we were pretty sure was going on was that all the patients weren't as well optimized as they could be. So we got an agreement with the orthopedic department and got all these patients, really every single one of them, funneled into the optimization program. And so far we are seeing outstanding results in our hip and knee joint replacement program. And these infections, as you can imagine, are tremendously, tough for the patients, very morbid, oftentimes requiring removal of the of the prosthesis, not being able to bear weight on that limb for a long period of time. So a lot of suffering involved with those infections. So you know, most joint replacement surgeons are really just maniacal about trying to prevent infection in their patients. And so we were really happy that we could forge this partnership to the benefit of our patient outcomes here at JPS.
We started that in June of 2019. Same-day cancellations is a huge problem for any hospital. In 2016, our facility lost $1.75 million due to costs associated with same-day cancellations. That year we had 838, and you can see it's trended down fiscal year to date, 110.
And there are multiple, these are all-cause cancellations, so, you know, somebody doesn't get a ride, whatever, you know, that's still counted in this number, but the number of cancellations that have been associated with a patient arriving and not ready have been reduced by over 50%.
Next. Oh, that's my partners.
What questions do you have for Diane? Sir?
Some other facility might have a lot of problems with delay, surgery delay that causes a lot of infection. Do we need to track that? It seems like we don't have that problem, but just want to raise that question.
Delay of surgery to what?
Because of missing tools, you know, up on the floor, they have to go and get sanitized,
Sterilized.
Yeah.
Sterilized, all that stuff. It may cause delay. Do we have any of that challenge?
I'll bet the OR does, because that's something that they manage with all the materials that are associated with each procedure.
And more important than that, and I'll shout out one of our providers who, you know, kind of leads the way in this, and that is Hugo Sanchez, one of our joint replacement surgeons, but more significant than having a surgery delay because of something falling on the floor is using an instrument that has been compromised in some fashion, and he has for years been very meticulous about his instruments and making sure that everything's ready, and especially trained his staff to make sure of it. And he has phenomenal outcomes in terms of surgical site infections, and has had for a long time. So you know, being meticulous, I mean, as Dr. Weber will tell you, being meticulous about your instruments, being meticulous about your technique, being meticulous about how you prepare your patients for surgery are all critical to how well your patients are going to do. And so much of surgery, you know, the outcomes of surgery are so much determined by what you've done up front to be ready, you know, in terms of your operative plan, in terms of preparing the patient, in terms of making sure that your team's ready for outstanding work.
One of the more underappreciated groups of people that, and I used to go and visit them at least once a week, are the people that clean the instruments. And they're well worth a surgeon's time just to stop in and every once in a while say hello, buy them lunch, because they don't get to see the light of day in the instrument cleaning room. But that's just it's good. Go ahead.
How early are the patients referred to you to get Optima?
Nowadays, quite early, especially from the ortho joint side. The minute that the decision is made between the surgeon and the patient that they're going to proceed with surgery, they come to us. And we do, sometimes if we only see them once, they're good to go. We just get the labs ordered and make sure they make it to joint class. Some of them, we are working on some nutrition. We're going to get their diabetes better controlled, and we form a partnership with that patient and the family, and it's all hands on deck.
Okay. Well, I just want to say it's an excellent review of what you're doing, and the outcome is very good. So I'm very glad to get the report. It's really good. Thank you.
Have you seen any impacts on transfusion rates relative to optimization of hemoglobin hematocrit pre-surgery? Have you looked at that
Fascinating.
yet?
I don't think we've looked at it.
I don't think we've looked at it. I know there was a decrease in transfusions with our blood conservation project.
Yes.
We do screen for anemia. We put them on iron. We'll do a workup and we'll send them to Hem-Onc. But honestly, there's not a ton of those patients.
Brian.
One thing that's not in there as a positive is the ease for the patients to be able to go downstairs. It used to be next door, but to go downstairs, we have one-on-one communication with them. Patient gets in very quickly. You know, a lot of these patients are in a lot of pain for a long period of time. Hip replacement, they can't get around, they can't ambulate. They get in, they get fixed quickly, we can get them on the surgery schedule a lot quicker. And I don't think that's a number that we can actually look, but it does. The patients get in a whole lot quicker, and that's the ease of them getting through the system. One person that's the quarterback that's basically able to get them to the different specialists quickly, get them back, get all the lab results, and clear them is beautiful.
It's a shame we can't throw football. We're able to, especially with the podiatry patients, because they're seen so frequently, we can make our appointment the same day, so the transportation barrier is minimized.
Good. Great data. Good work.
One of the things that I wanted to mention, our communications team, the video that y'all saw earlier, we do those in-house now, and oftentimes y'all as board members will say, how are we communicating with the community? How do we get information out about JPS? We're doing a lot more of those videos, and those videos become part of our social network system. And they're out on Facebook, and they're out, and they're linked to others, and that has been a huge benefit to us. Also, thanks to NBC and others that are now, CBS and NBC in particular, which are much more interested in doing stories about JPS, about what's happening. And we're greatly appreciative of them allowing us to communicate with the public. That story aired on NBC. CBS also seems to be very interested in trying to get factual information about what's going on about JPS, so we're greatly appreciative of the news media wanting to do stories on that. Diane won't mention it, but the story that you saw, she had to run home. Well, she didn't run home, she was at home because that was her day off. She had to get her lab coat on, come in, act like she works every day like that. Because
I was clearly not prepared to be on television.
We have a great communications team that gets the television interested, but we oftentimes don't get the opportunity to pick the exact time. So it was wonderful. So you coming across like that with the kind of care you give is really powerful, and that's what we appreciate.
Very good. Thank you.
Very good. We don't have anything else except, before we go into closed session, you got a couple comments about coronavirus?
Yeah, I was going to mention to y'all, obviously, and you saw it in the television and newspaper media, we had a potential case that had come in Tuesday morning at about 10:45. It was a patient who had traveled to Italy, felt that they had some symptoms of what they thought might be coronavirus. They came to us, and that was not the case, but it was a wonderful example for us in knowing how prepared we are. And our team did an unbelievably great job. Our emergency department, how the patient got here, working with public health, working with ground transport, everything worked. And sometimes in these kind of situations, you have an incredible amount of Monday morning quarterbacks, people who are not in the situation, don't have seconds to make decisions, and you've got 4 hours to look at it, and our folks have 10 seconds to make a decision. Our team did an incredible job. What you're getting passed out is pretty much the details of that case, so I won't go into that. But I think our team has done an incredible job. And Dr. Bryant and some of the others, and our whole team down in the ED, we limited the amount of people that would even see the patient. The patient went directly to a quarantined area, and we were prepared. The coronavirus, Ebola, all the others, these are not going to be one-offs. These are going to be something that we're going to always have to deal with, and they're all going to have their nuances, and they're all going to have their situations that make them different. The challenge is no one can expect to know all the answers. CDC is doing the best they possibly can do to provide us the advanced warnings and how to deal with it, but they don't know all the answers. So we're trying to deal with it on a moment-by-moment type situation. So our team did a great job. The other thing is we're trying to do the best we can to communicate the information that we know. the information that's given to us by the state health departments, by our local health departments, it's given to us by CDC. We as a public hospital feel that's part of our responsibility to get information out to the public. We're doing the best we can in all avenues that we have. So Dinah Brodeur, if you don't mind, if you come up to the mic and let you do a real quick rundown of just some of the information that we're getting out, and also your work with the other area hospitals and how we communicate this. You all have met Dinah Brodeur, but she's our Vice President of Communications, and a lot of what you're seeing in our communications is her and her team that make those things happen.
Sure. I'll speak a little bit about Rob's team too, the quality team, infection prevention. They are our source of truth, and they're working closely with the CDC and Tarrant County Public Health to get that right information, to give it to us, where then we're able to push it out in every which way we possibly can, because we have a huge responsibility to get it out to not just our patients, our team members, but also the role we play in the community. We have to get that information out. We've worked closely with Tarrant County Public Health, and I really like what we did yesterday, where we did the first live chat that we've done on Facebook. It didn't have a ton of people participating in it, but what it said is that we're there to answer your questions, we're there to help you. And I think that's really important, that we seize those opportunities to show people that we're there for them and to build the trust now so they know they can count on us when they need us.
What Dr. Podolwitz talked about earlier about understanding the patient and understanding what they had gone through, we need to understand that there are 6,700 caregivers in this organization at all different levels, and they too have fears, and they too have concerns, and they too have oftentimes a vacuum where they might not know. So we're trying to do the best that we can. We're also trying to deal with a community effort of different messages that the community will hear, and when fear factors become inordinate or not necessarily in some cases reasonable, it's not ours to judge reason or not. It's our job to constantly do our best to educate. When asked the question, are you doing enough to educate? The answer to that is no. The answer is never going to be yes. The answer is, can you do everything you possibly can at different levels? And that's what we are trying. We don't use one form. We used yesterday in Facebook. We use our monitors that we have in our clinics and throughout the hospital. We use our team members. We use the executives. We use directors, managers. All those, you heard earlier about our ambassador program, 450 people that are part of the organization at different levels. We use those as communication tools to go home to family and talk and do those discussions. So we're doing everything that we feel we can do, but if there are suggestions, we're open to those, and we are never callous to the fact that people are going to be hugely concerned when every story and every bit of news information is about it, and sometimes it's conflicting. And so we're going to do our best to stay a very steady course of being pragmatic, methodical, and the caregivers that we are. Yeah, Amanda, I'm sorry, I didn't mean to interrupt you.
No, not at all. I was just going to give compliment for the event yesterday. I was able to share that on all of my other social media because there were so many questions coming through. I think that's a good use of technology and being able to make sure that that information is getting out. I plugged it into specific community members, and they really enjoyed that type of communication and level of communication with JPS.
I love that feedback. And what was exciting yesterday, because we did that in partnership with Tarrant County Public Health, they sent someone over too to answer questions, is that the people in the room at that time, the epidemiologist, infection prevention people, Tarrant County Public Health, were so excited to be doing this. I mean, the energy in the room was wonderful. They were thrilled to be answering those questions at all levels. So I know that's something that, I wish there was a checklist for this and we could say we did these 6 right things and now we're done and we've communicated this well. This is a marathon, and so I'm sure we'll come back to more live chats and we'll tweak that. So as you see needs and as you hear things and think of things, either people that need to be communicated to or ideas that you have, pass them on, please.
Thank you, Diana. I appreciate it. Thank you, Mr. Chair.
I have a little vignette for you. You know, yesterday they talked about covering your mouth when you sneeze, don't touch your nose, don't touch your eyes, et cetera, et cetera. And Steve shared with us yesterday a short story that he was watching CNN, and the person that was giving the instructions about what you should not do was doing the following. And I went home and I told Martha about it, and we sort of laughed, and then in the middle of the presentations today, it dawned on me I had been doing the same damn thing with look in my Lordy, lordy, lordy.
We can all learn, we can all be better.
Yes.
We will do that.
Okay, we've got to reconvene the executive session pursuant to Chapter 551 Texas Government Code. So we'll reconvene at 14:30 hours. Thank you all.
Steve, why are you watching CNN?